This is a poster presentation on venous thromboembolism prophylaxis, prescribing and deprescribing in frailty patients. My name's Catherine Stark, and alongside Megan Kelly and Andrew Degnan, we carried out this QI project. Background. Frailty patients are some of the hardest cohort to manage VTE thromboprophylaxis because they are highest risk of both VTE events and bleeding. Over 60% of all VTE events occur in those over 75 years old, and frailty patients with their increased age and comorbidities significantly increases their thrombosis risk. The risk persists for up to 3 months after an initial provoking factor. Therefore, it's really important we think about prescribing VTE thromboprophylaxis in acute frailty admissions. The caveat to this is they are also the highest cohort of bleeding risk. The number one location for bleeding is the GI tract, and the number one mortality is associated with intracranial bleeding. Therefore, it's really important we think about deprescribing when the bleeding risk outweighs the thrombosis risk. Important to consider here that the bleeding risk associated with prophylaxis is much lower than the bleeding risk associated with treatment. If we fail to provide prophylaxis and the patient goes on to develop thrombosis, the anticoagulation associated with the treatment of VTE is much higher risk due to the higher dose and duration. The American Society of Hematology have published guidelines based on current database that shows that extended VTE prophylaxis post-discharge to carry out for the extended risk that persists up to 3 months is associated with increased bleeding, and this is likely to be even higher in our frailty patients. Aim. We aim to improve VTE prophylaxis, both prescribing and deprescribing, in patients admitted to an acute frailty ward, which is Ward 8 of St John's Hospital, Livingston, NHS Lothian, by December 2024. Methodology. We identified 2 points for review of their VTE thromboprophylaxis prescribing. Point 1 was when the patient is admitted to the acute frailty ward, and point 2 is when a patient is deemed a delayed discharge. This means the patient is medically fit for discharge and at their functional baseline or has a new established functional baseline and is waiting for social care input. And if the social care infrastructure was in place, they would be discharged from hospital. It's at this point that in most patients we feel the bleeding risk will outweigh the thrombosis risk as per the American Society of Hematology guidelines. Initial data collection consisted of a medical staff survey of all the current doctors working on Ward 8 of St John's and 2 initial data sets 1 month apart. Exclusion criteria was patients who are end-of-life care or those already on oral anticoagulants. After the initial data collection, we carried out interventions. This included medical staff education through PowerPoint presentation of the current medical staff in Ward 8. Our biggest intervention was creating a track care, which is the electronic inpatient record system, pro forma, with a backslash that auto-filled a delayed discharge summary, which was /Ward 8 DD, which you can see here on the slide. This summarised the patient's admission thus far, the plans for discharge, and also highlighted VTE prophylaxis as a point of review when the patient's made a delayed discharge to consider deprescribing. There was also a simultaneous QI project on the ward that developed an admissions proforma highlighting VTE prophylaxis prescribing as a point of review when the patient's admitted to the ward. Results. From the staff survey, we found that only 44% of medical staff considered deprescribing VTE thromboprophylaxis when a patient is delayed discharge. Only a third knew how and where to access the VTE prophylaxis intranet guidance, and as a team, we felt much less confident about deprescribing compared to prescribing VTE prophylaxis in frailty. Our pre-intervention data collection showed there was a mean percentage of only 54% of patients on correct VTE prophylaxis on admission to the acute frailty ward, and 40% of patients remained on VTE prophylaxis despite being fit for discharge awaiting social care. Also important to discuss here that not only by deprescribing are we reducing the bleeding risk of the patient, but we're also reducing the cost to the NHS because each graduated syringe of dalteparin costs almost £3. If patients remain in hospital for many months, over time this can be costly. We now demonstrate the 2 run charts from the data collection post-intervention compared with pre-intervention, We can see here that post-interventions we improved, so there was 74% of patients on correct VTE thromboprophylaxis on ward 8 admission, which is a 28% improvement from the pre-mean results. The biggest success of this project was deprescribing VTE prophylaxis. We can see after the interventions, only 16.7% of patients remained on VTE prophylaxis when deemed delayed discharge, which is a significant 60% improvement from the pre-intervention mean. To conclude, based on the American Society of Hematology guidelines, extended VTE prophylaxis post-discharge is not recommended because of the higher bleeding risk compared to thrombosis. The percentage of patients remaining on VTE prophylaxis once deemed delayed discharge in this QI project improved by 60%. Acute frailty patients are some of the highest risk for VTE events, and this QI project managed to improve VTE prophylaxis prescribing on admission to the ward by 28%. Through the creation of this proforma, we also have the added benefit of summarised documentation that's clear and concise for those patients who are delayed discharge and may remain in for many months awaiting social care. Next steps. We plan to resend the staff survey to look at the post-educational results, ensure the continued use of the new proforma as each rotation of junior doctors rotate through the ward, and we carry this out through creating an induction presentation so those starting on the ward are aware of the work and the importance of this project going forward. We're also trying to extend our work from the acute frailty ward to also be involved with the orthogeriatrics ward, but it's important to note that VTE prophylaxis in surgical patients will vary from medical patients. However, they also have a significantly high number of patients that are awaiting social care input, and therefore it's really important that a clear VTE plan is in place at the time the patient is deemed fit for discharge. Please find the references attached below. Many thanks for watching this presentation. Hello.